Since morning, there were four speakers who talk on this spinal cord injury. But I think they have designated only one talk on a stroke. But for PG, the stroke and SCI, you are going to get either one of these cases during your practical examination. So both carry equal weightage and equal marks. Okay. And I will try to do the job of four speaker single-handedly. Okay, so I might skip some slide or hasten some slide. Okay, but you are free to ask question. So moving on to the talk, the stroke rehabilitation. So my objectives are that when you get a patient with a stroke, either referred to you or directly went to you, you should be able to assess based on the history taking examination as you have taught by Dr. Yusing sir in the morning session. Again, you can appreciate the role and a skill set of different member of the rehabilitation team, that is the teamwork, and understand the different environment in which the stroke rehabilitation can be done, that is OPD setting, community setting, home-based setting, and IPD setting. Recognize various aspects of assistive devices, the recovery process, goal setting, planning, and reintegration following a stroke, including community participation. This is my objective of this talk. So, as per American Heart Association and Stroke Association, you need to have a definition. It's a medical condition that occurs when there is an interruption of blood flow to the brain, which can cause brain damage and death. The mortality rate due to a stroke has decreased, but the incidence of a stroke has increased, resulting in an increased socioeconomic burden in the form of residual disability. But there is a wide diversity in stroke patients and stroke severity. Out of those who admitted in a hospital, only 65% of the survivors receive rehabilitation. So there is a wide gap between the patient who receive rehabilitation and those who have not been offered rehabilitation. And this is one most common question you faced during your practical examination. How will you clinically differentiate a stroke from ischemic or hemorrhagic? So if there is acute onset, the prominence of headache, vomiting, neck stiffness, increase in BP, and rapidly developing neurological signs, then you can answer it might be due to the hemorrhagic stroke. And based on localization, based on clinical presentation, you can localize the site of lesion inside the brain. So here, if headache is there, so most likely it's due to hematoma. Vomiting indicate increased ICP. Okay. A prodrome consisting of numbness, tingling, and weaknesses, it's pointing towards ocular bleed. Again, there is loss of all sensory modalities. Then you can say chances are there of having a thalamic hemorrhage. These are the recommendation. All patients with acute stroke should be assessed to determine the severity of the stroke and early rehabilitation need. Patient who admitted to hospital with acute stroke should have an initial assessment at earliest. As evidence level, so here is A. So whenever a patient is being admitted, even in ICU or even in emergency, you need to go there if a case has been referred to you, obviously. Otherwise, you have to wait for the patient to shifting to you. But assessment need to be completed. Evaluation of patient functional status, safety, physical readiness, and ability to learn and participate in rehabilitation therapies. This is very important because why you are taking the patient to your ward or your side unless until he don't have any ability to learn. So initial screening and assessment should ideally be commenced within 48 hours. For the assessment of impairment, functional activity, role participation, environmental factor, it should be conducted using standardized valid assessment tools. And many assessment tools and skills has been very well described by Dr. Binay Goyal. Even those patients who cannot be able to communicate, for those you have to, specific tools are there that you can download or write through this site which I have cited here. These are the recommendations on initial stroke rehabilitation assessment. So you need to assess for dressing, grooming, personal hygiene, feeding, functional mobility, communication, and identify potential discharge need. A screening for not admitted cases. All cases are you are not going to admit. Okay, so patient has to fit according to the goal setting and plan, whether you going to take that patient or not. And again, they need to be screened for the need to undergo a comprehensive rehabilitation. It's not like that one part or two part. Comprehensive assessment for comprehensive rehabilitation. And those patients who don't fit or meet the criteria for rehabilitation, what you are going to do? You are not going to tell them, though, don't need rehabilitation. No. You are again going to reassess them. For rehabilitation, it might be reconsidered. What you are going to do? Weekly during the first month, and at an interval as indicated by their weaknesses and clinical presentation. These are the priority area: swallowing, communication, and mobility. And the additional screening required for onset of depression, cognitive ability, environmental factor, and other modifiable risk factor, those who are present in a stroke quite commonly present with. The core rehabilitation team, okay, you need to write it in your this theoretical examination. Okay, these are the physiatrist, and this rehabilitation occupational therapist, physical therapist, sleep language pathologist, rehab nurses, social worker, and dietitian. Also write in your theory the patient and family members. Don't forget to write it. It will fetch you extra mark. If you mention the patient and family member, they must be included in the as a part of core team. Additional team member you can write: recreational therapist, psychologist, vocational therapist, educational therapist, rehabilitation therapy assistant. All members of the rehabilitation team should be trained, specialized training in stroke care and recovery. This rehabilitation therapy assistant we have at our place at AIIMS Patna. Okay, specifically we ask our director, because it's not possible for a physical therapist to do rehab session 30 minutes twice a day for every patient, 30 patient in IPD. So we have been provided with rehab assistant. Those are basically health assistant. They have been trained to take care of SCI, TBI or stroke patients. There is strong evidence that the organized and interprofessional stroke care can reduce mortality, long-term disability, institutional care, and it also reduces the length of stay. Rehab planning. Once a patient with a stroke has undergone assessment, a standardized approach is recommended to determine the appropriate goal setting for rehabilitation. Then you will decide to do what kind of rehabilitation: IPD, OPD, or community-based. The goal is to enable a stroke survivor to reach and maintain their optimal functioning level by providing the skill set and tool needed to attain independence and self-determination. These are the important factors that will influence the decision to accept a patient for IPD rehab. That is pre-morbid cognition, pre-morbid mobility, and pre-morbid communication. If patient is paralyzed before the stroke, then you cannot expect that patient is going to run after your rehabilitation. Similarly, before the incidence of a stroke happened, pre-morbid conditions are very important, and it to be noted in the history sheet. These are the common conditions with patient present with pre-morbid condition like hyperlipidemia, diabetes mellitus, hypertension. Okay, pre-morbid functional stress, as I said, also important. Perception of impairment, whether he was amputee before the stroke. Likewise. And these are the IPD consideration in order to reduce the burden of intensive rehabilitation should be performed to maximize stroke patient ability to perform ADL, hasten the recovery period, and secondary prevention measure to prevent the recurrence risk of a stroke. Dr. Henry was mentioning regarding, he write 3 times, prevention, prevention, prevention. He wrote prevention of this pressure injury. But again, the prevention of recurrence of pressure injury is also very important. Okay, so at the time of discharge, we must also talk about the prevention of recurrence of pressure injury. Similarly, recurrence of stroke need to be prevented. These are the acute IPD care. The medical, obviously, medical stabilization is a priority. Acute stroke treatment along with implementation of preventive measure. And medical management should focus on stroke prevention. Or what are those? Prevention of hypertension, dyslipidemia, diabetes, weight loss, physical activity, nutrition, and smoking cessation. Rehab in acute phase. Administering early mobilization of a stroke patient within 24 hours onset. But it is not clear exactly what is the optimal timing and what is the frequency. But literature are suggesting or in our favor of early mobilization. Early mobilization is recommended within 24 to 48 hours of a stroke, as it improves functional independence and walking ability in a stroke patient, unless until contraindicated. So you try to talk to your neurology colleague, PG, SR faculty. If they are not referring the cases of a stroke to you within 24 to 48 hours, you go and reach them and try to convince them, sir, please refer these cases. And as per the guideline, they need to be rehabilitated, and rehabilitation need to be started within 24 hours. This is the most missed part from our part. Okay, whenever patient come to us, we never bothered about this nutrition and hydration status. This is very, very, very important for everything. Pressure injury management and this CI management, nutrition. It should be a screen for malnutrition, ideally within 48 hours of IPD admission with valid screening tools. Can be re-screened for changes in nutritional status regularly through IPD, prior to discharge as well as periodically in OPD. Result can be used to guide appropriate referral to a dietitian. Patient with nutritional concern, hydration deficit, dysphagia require nutritional reintervention and should be referred to a dietitian. Most of the time, IPD patient develop this electrolyte imbalance, fluid deficit. Okay, their sensorium get altered, and we are not bothered why it is happening. So, if you have to keep very vigilant eye on nutritional and hydration status. Dietitian provide recommendation based on they will give the enteral nutritional support in patient cannot safely swallowed. NG tube feeding is if for prolonged period of time, then they will go for this enteral feeding through enteral feeding. Motor impairment due to a stroke, it limits patient ability, mobility, and negatively affect their return to the workplace. It can also reduce patient quality of life. Therefore, optimizing the recovery of motor impairment after a stroke is very important. Exercise therapy. There is no superior exercise therapy method among various methods that have the effect of improving motor function, such as we say this exercise relearning, neurophysiological approach, Bovath approach, neurodevelopmental approach, and biomechanical approach. But it is recommended to apply them individually or in combination according to the patient condition and your experience. HIIT, it can have positive effect on the recovery of cardiovascular system, endurance, pulmonary function, motor function. So it is recommended with appropriate medical evaluation and consideration of coexisting condition and functional limitation. It is recommended to increase the total amount of exercise therapy, considering the patient neurological and medical status to improve ADL and motor function. So high intensity interval training is recommended. Again, the training need to be task oriented. Facilitate restoration of gait related activities, interventions such as treadmill training. Bed is bad. Bed, I am telling you, very bad. So keep your patient very much engaged from morning till night. Keep them very much engaged in ward by doing whatever kind of activity, like reading newspaper, doing this spiritual thing, doing meditation. Let them move to the occupational therapy section, various handle exercises. Even the evening, you just let them with attendant go to this hospital. If you don't have a park or like big tree, as in CMC, okay, just let them roam around this hospital premises, keeping the safety in mind. Just going outside, looking towards the sky, gauging the sky, looking toward the star, it has a great effect. Now PRE, for upper limb weakness and lower limb weakness, progressive resistance training is recommended for improving strength, motor function and ADL. Treadmill training, this is also very much recommended. However, there was no insufficient evidence regarding the long-term effect of treadmill training on the improvement of gait speed and endurance. It will help in the patient getting discharged from your hospital. The length of a stay will be reduced, but long-term effect, we don't have any sufficient data on that. This article came by Munari and et al. In 2020. They reported a pilot study, that is the effect of backward treadmill training. What they are saying, it facilitates the hip extension, knee flexion with the foot position behind the trunk. So it is helpful for restoring motor function in patient with a synergistic pattern in the lower extremity. I don't have any experience regarding this backward training, but let's see, we can check it out. And again, the biofeedback for the function of lower limb. Combining biofeedback with physical therapy led to significant improvement in muscle strength, functional recovery, and gait quality. That is everything you are looking for as far as motor recovery is concerned. And again, however, the long-term effect of biofeedback were not confirmed. The FES, okay, FES is recommended for both UL, upper limb and lower limb, function and improving ADL in stroke patient. So again, write all these points in your theory exams. Okay, these are all important points, but you must write it. It seems very traditional, conventional, but you write it. FES, the mirror therapy, the upper extremity function and activity. Okay, lack of bimanual use significantly limits ADL and participations in occupation. Okay, don't focus only on the unhealthy side or weak side or hemiplegic side or hemiparetic side. Most of the time what happens, we forget about the healthy side. Okay, so two interventions, those used frequently in clinical settings are CIMT and neuromuscular electrical stimulation. CIMT, you know, the protocol varies from 3 to 6 hours per day. CIMT you will get as a short note, okay, or even in this practical examination. So 3 to 6 hours per day for 5-day week, for 2 weeks, or can be modified as 1 hour per day for 3-day week, for 10 weeks. And both demonstrated improvement in upper extremity participation as far as ADL is concerned. It is recommended to improve UL motor function and ADL. Neuromuscular electrical stimulation is an effective intervention for a stroke patient who have limited vocational control. It can be applied to the shoulder joint, okay, because it's very common, na? You get sulcus sign positive, shoulder subluxation, again you are utilizing Bovath sling and everything. So NMES can be helpful in this regard. The neuroplasticity, the enigma thing, I even don't understand what exactly it is, when it develops, how it comes, how it goes, how it helps, but you need to write it. It continues well beyond the acute recovery phase. Best practice and research strongly support intensive, repetitive and salient task-specific intervention to promote neuroplasticity and functional recovery. It is the brain ability to reorganize after any injury. Again, AFO we are very much familiar with. In a stroke patient with foot drop, you ping me 5 minutes before, okay, so that I know which slide to skip or which slide to fasten. Regarding AFO and FES therapy, the more effective in improving walking in a stroke patient with foot drop. No method can be said to be superior, so they should be applied selectively according to the patient condition. We all have this portable FES with us. Okay, so it can be applied to the AFO. When you are training the patient with AFO, you just try to use this FES. The battery powered small device FES that can be attached to the AFO. Again, RTMS, few of our AIMS has procured RTMS. We have not procured yet. So it has a positive effect on improving upper limb motor function, grip strength and hand function. So it is recommended. The evidence for RTMS to improve lower limb function in a stroke patient is insufficient at this point of time. Robotic rehabilitation, it's useful for improvement in upper limb and lower limb function as well as ADL, comparing to conventional rehabilitation therapy. There is promising evidence for the use of robotic assisted walking, which appears to be more beneficial than a conventional treadmill training. Now VR, virtual reality, it effective in improving upper limb motor function. And it also effective in improving balance. So Dr. Binay can check it out on his patient who is having this corrected of motor power but having some problem with the balance. So you acquire this VR at your hospital and try it. Now this has also been seen that the transcranial direct current stimulation can have a positive effect on the improving upper limb motor function. Motor imagery, it is also helpful. Balance training, it is recommended. FES, NEMS, both are recommended. As a modality or as an orthotic evidence, it supports that a stroke patient show improvement in muscle activation of the muscles stimulated even those not wearing a device, thus promoting recovery. But in upper limb, upper limb recovery post-stroke, there is a statistically significant benefit from FES when applied within 2 months of stroke on ADL participation. Mirror therapy, aerobic exercises, occupational therapy, speech language therapy. After a stroke, you may have trouble understanding what patients are saying. You may also have trouble writing, speaking, or finding the right word for what you want to say. You may also need a speech therapy if you have trouble swallowing when you eat or drink. So this type of therapy may include way to strengthen the muscle you use when you swallow. Basically, this topic is going to be covered tomorrow by one more speaker. Now, considering the comorbidity and functional limitation as well as accessibility and providing community-based long-term intervention, it may help to improve the exercise capacity. So it is recommended, and train the patient who are returning to home about the exercises so that they can continue at their home with the help of the caretaker who are with them in the time of hospital admission. Now, these are the common complications of a stroke: spasticity, dysphagia, aspiration pneumonia, DVT, joint contracture. This is the spasticity prevention update: proper posturing, range of motion exercises and stretching, AFO, botulinum toxin and other injection, and it is also recommended to perform splinting or casting in conjunction with the botulinum toxin injection. Don't forget the patient after injection. Oral administration of tizanidine, baclofen and dantrolene, that is not available, are recommended because they improve clinical muscle tone with a low risk of serious adverse effect. Intrathecal baclofen infusion when it is recommended. Dysphagia, 15% of stroke survivors had dysphagia at 1 month. So we need to do some study like video fluoroscopic swallowing study, okay, fiber optic endoscopic swallowing study. It will be covered tomorrow, I think. Now the patient, families and caregivers should receive education about swallowing, prevention of aspiration, to reduce the risk of aspiration pneumonia. This aspiration pneumonia is a huge setback for this stroke rehabilitation. Whenever this will happen and whenever this will occur, you will be in great trouble. Either we will call the medicine people, transfer the patient back to your ward. Patient has developed this aspiration pneumonia, again RTI, and every infective maybe went to sepsis. So you must be very careful about preventing this development of aspiration pneumonia by properly evaluating the patient for swallowing and this dysphagia. Joint contracture on the affected side within the first year of a stroke. So daily stretching exercises are needed to prevent joint contracture. Static positioning of the shoulder in maximal external rotation, 30 minutes a day. A splint are commonly prescribed for both upper and lower extremity. Resting hand splint in conjunction with the early spasticity treatment. AFO. Pain. Pain can affect the shoulder or the entire hemiplegic side. The thalamic pain, the CRPS, many type of pain we get in a stroke patient. So hemiplegic shoulder pain primarily due to shoulder subluxation and is correlated with the changes in muscle tone, weakness, injury and shoulder tissue. The result is functional impairment of the upper limb and negative impact on rehabilitation, leading to depression and poor health related quality of life. So we have many modalities like injectables, RFA, the physical modality, pharmacotherapy for pain management. Non-invasive standard of care provided by the physiotherapist, prosthetic and orthotist, and occupational therapist include restoring scapular and humeral alignment, stretching within a pain-free range, strengthening the scapular and shoulder muscles, thermal modalities such as ice or heat treatment, and proper orthosis. Cognitive dysfunction. Tomorrow you have a lecture on this. And the skills already discussed by Dr. Binay. Gait and balance impairment. A variety of interventions are available for a stroke patient without a specific approach proving superior. So, successful treatment are based on individualizing the intervention to specifically address the patient impairment and functional limitation. The use of AFO on the hemiplegic lower extremity along with assistive devices such as cane are common compensation strategy that improve balance and gait. But we have this foot plate, the balance master, the equivalence system. These are all with us. And again, to prevent the patient from fall. All patients should be screened for fall risk. Every patient of stroke must be screened for the risk of fall. Communication and language impairment. The common include aphasia, dysarthria, and apraxia. Okay. Aphasia affects speaking comprehension, reading, and writing. Dysarthria is a group of motor speech disorder from weakness and lack of coordination. And apraxia disorder, motor planning. All these communication disorders are very negatively affect social participation and quality of life. Treatment approach for aphasia. Okay, I am skipping this slide. Okay. Fluoxetine is considered, this is a recent trial, FLAME trial. They have shown the success of this fluoxetine as a selective serotonin reuptake inhibitor, and it also can affect the antidepressant as well as psychological well-being. It actually elevates the mood of the patient and prevent the development of the depression. Incontinence, the urinary and fecal incontinence. The management of bladder incontinence, bladder care you have already been taught, I think. Toilet schedule, the pelvic floor muscle exercises, addressing functional mobility. Now, stroke rehabilitation and recovery. These include prevention, medical management of comorbidities, an individualized rehabilitation program that include appropriate assessment and treatment based on the International Classification of Function, Disability and Health. Having a supporting family has a crucial role to play in the recovery of the patient. That's why I told you, during this team for the stroke care or team rehabilitation, always include the patient family members. What we used to do at our place during admission and before the admission, during the counseling of the patient caregivers, we tell them, you need to learn everything. Like the physiotherapists are coming to your side, they are doing the exercises, doing it twice a day, 30 minutes each session. So better to learn these things. And even sometimes you do it yourself in presence of the therapist so that they can see and supervise how you are doing it. Because after the discharge, you are going to home and you have to do it. You don't have to call a physiotherapist or have a physiotherapy session at home. We don't want that. Similarly, occupational therapy training, we involve our patient caregivers, actively involve them. That's why, again repeating my word, bed is bad. Don't let your patient lie on the bed and thinking about his future, present and past. Okay, get them engaged, very much engaged. Even in the morning, give them a routine. You have to brush by this time, you have to take breakfast by this time, do some puja, do some Hanuman Chalisa, do some meditation, whatever it is. Okay, again let them go to rehab session, again everywhere, read newspaper, but get them engaged. Engagement is very important for their motivation. So, conclusion is, stroke rehabilitation requires a well-coordinated multidisciplinary team that systematically evaluate patient to identify impairment that affect his ADL and participation in life. Research demonstrates coordination between medical and rehabilitation intervention is important to optimize the functional outcome. Current evidence demonstrates that recovery continues year beyond the initial stroke advocacy. So, services continue beyond this discharge. So, thank you. Time up. Okay. So, just 1 minute, more minute. I have actually tried to include everything because stroke rehabilitation is not a one topic that you can conclude in 25 minutes. It is a one-day presentation. So, for management, you start from history taking, clinical evaluation, assessment based on standardized tools. Okay, then you do this rehab planning and goal setting, and accordingly you decide whether to admit the patient in IPD, OPD or community based, and everything you need to know, starting from the exercises, what I said, the modality, the training, the gait training, balance training, the dysphagia, the swallowing, everything, aspiration pneumonia, nutrition and hydration status. Again, I am repeating this. Don't ignore the nutritional and hydration status of the patient. And the recent, this gadget has come to you, this RTMS, transcranial direct current, and virtual reality, augmented reality. Now it is also coming up. So everything you must keep in your mind. So thank you. Any question? Anybody?
Thank you, sir.
PG specifically, Venu sir has repeatedly asked you to ask question, doubt. Because don't get confused. SCI and stroke, both has equal weightage, equal marks. And out of these one long case will be either of two. That is fixed. You are from which place?
So I am from Ethnither.
Okay, good.
So I have a question, sir. Until how many days or month post-stroke we should continue therapy
for peak motor recovery?
Very good question. Actually, at the time of discharge planning and at the time of admission, whatever skill you are following at your place, like suppose you are following FIM, so you will compare the FIM at the admission and at the discharge. Then you will know what are the challenges has remained to be assessed or addressed. And again, at the time of discharge, now don't forget the address of the patient, from where he is coming and how he is coming and what kind of environment he is going to live. So at the time of discharge itself, you can say everything about the patient. These are the things which are left. And again, ask the patient, what is he expecting from you? And going for community and integrate into the community and family, what are the challenges he is facing? And accordingly, you will plan. Based on all these things, everything will count under that.